Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us for our program today, Zika virus and update for clinicians. Today, we will provide the latest details on the Zika virus, including updates to previously provided information for clinicians that provide care for pregnant women, infants, and children. If you have a question about anything being discussed today, please call or email during our broadcast. We would like to ask that you wait until the end of this webinar to ask questions. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year for nurses, expiring on May 31st, 2017, and 2 years for social workers, expiring on May 31st, 2018. I'm Dr. Mary McIntyre, Assistant State Health Officer for Disease Control and Prevention and State Epidemiologist at ADPH. And joining me today, Dr. Tom Miller, our State Health Officer, Dr. Karen Landers, our Assistant State Health Officer for Public Health Area 1, and Dr. Scott Harris, the Assistant State Health Officer for Public Health Area 2. Welcome, everyone. We have a lot of important information to cover today, so let's get started. What we would like to do in today's session is actually describe the epidemiology, clinical manifestations, and the latest information on management and prevention of Zika virus disease. You will also be able to discuss current recommendations on diagnostic testing for Zika virus infection, articulate the importance of early recognition and reporting of cases, review the latest recommendations for pregnant women and others with possible Zika virus exposure, and discuss the evaluation of infants with microcephaly, intracranial calcifications, and other abnormalities linked to maternal Zika virus infections. So at this time, we will go ahead and get started with the program. At this time, Dr. Scott Harris will actually give you information on the epidemiology of the Zika virus, clinical signs and symptoms.
Thank you, Dr. McIntyre. Let's begin with a little bit of basic virology about Zika virus, and then we'll talk some about the vector transmission of Zika virus. Zika virus is a single-stranded RNA virus. It's actually a member of the flavivirus family, which includes a lot of the better-known viruses, including yellow fever, dengue, Japanese encephalitis virus, and West Nile virus. The word flavivirus actually comes from the Latin word for yellow, and that's because all these viruses are similar to yellow fever virus. We'll hear some today later about Chikungunya, which is not technically a flavivirus, but it is somewhat similar in other ways, as we'll discuss later on. Zika virus tends to be transmitted to humans primarily through the bite of Aedes, a species of mosquitoes. Aedes mosquitoes are actually very common throughout the world, particularly tropical parts of the world. Aedes aegypti is perhaps one of the most famous because it's known for transmitting the yellow fever virus. It seems to be a much more efficient vector for transmission of Zika to humans. But what we have in Alabama and in many parts of the United States is a cousin to that, known as the Asian tiger mosquito, or Aedes albopictus, which you can see on your screen here. All of these mosquitoes can transmit, besides Zika, also dengue and chikungunya viruses. All Aedes mosquitoes have evolved to live very closely with humans. They tend to lay eggs in areas of water around people's dwellings, so frequently they can be found around a drip pan under a flower pot or in a gutter where there's stagnant water. They've been known to breed even in a bottle cap or a discarded soda can. So these are mosquitoes that require only a small amount of water to breed. They typically do live in and around households. They may fly only a couple of 100 yards in their entire lifetime, so they're very closely associated with people. They can bite at night or dusk and dawn like all mosquitoes do, but can also be very aggressive daytime biters as well. This is a map that shows you the historical range of Aedes aegypti, and you can see that most of the southern United States had Aedes aegypti at least at one point. Alabama itself was a hotbed of yellow fever over 100 years ago, and you can see that this was part of the natural range for Aedes aegypti, historically speaking. What we've seen more recently, though, is that Aedes albopictus has become much more common, and you can see that albopictus is a little bit more of a versatile mosquito. It tends to have a wider range and live in areas that are perhaps a little more temperate. Albopictus also has the ability to feed off of other mammals, unlike Aedes aegypti, and so it does have the ability to spread and go to places where Aedes aegypti had not really been seen in the past. Currently in Alabama, we think that the mosquitoes are largely, if not completely, albopictus species. Aedes aegypti has not actually been identified here in over 25 years. And probably in the late 1980s, Aedes albopictus outcompeted the Aedes aegypti species, so that's what we're finding now. Now the next slide will show you some information about how Aedes is transmitted from mosquito to its host. The urban cycle or epidemic cycle that you see on the right side of the slide is the one that's most familiar to us. A person is bitten by an infected mosquito, acquires Zika virus, and develops viremia, so that when they are bitten again, the mosquito can take a blood meal from a viremic person and then go on and bite another person and so complete that cycle. However, there's also a sylvatic cycle, or what's known as a jungle cycle as well. Zika virus is like most all flaviviruses in that it can infect other non-human primates. So in parts of the world where you have apes or you have monkeys, you certainly can have transmission of the virus to those non-human primates and back to the mosquito, so that cycle continues even in a time when we don't have apparent human infections going on. Again, this has been most famously reported with yellow fever outbreak, when you may have a very broad vaccination coverage within a country, and yet you still have yellow fever transmission going on in a sylvatic cycle, so that when you have a non-immune host or you have people who stop giving vaccinations, then you can suddenly see sporadic outbreaks of yellow fever, even though it may not have been present for many years. There are certainly other modes of transmission, and we'll spend a good bit of time today talking about those. Besides transmission by mosquito, there's maternal fetal transmission, including not only intrauterine transmission, but also perinatal transmission as well. There's been a great deal of talk recently about sexual transmission, and we'll discuss that at length today. There's been documented transfusion-related transmission of Zika virus, as well as transmission by laboratory exposure. Presumably, because of what we know about Zika virus, we would expect that it could be transmitted through organ or tissue transplantation, although that's not yet been documented. Transmission through breast milk is certainly possible and a very real possibility as well. At this time, there are no changes in recommendations about breastfeeding, particularly in the developing world where there may not be nutritional alternatives. So breastfeeding should continue as before, but certainly that is another theoretical risk for transmission of Zika virus. This is a map that shows you the current areas where Zika virus transmission is going on, and you can see a little bit in the Cape Verde Islands near Africa and a little bit in the South Pacific, but primarily this is a problem in the Western Hemisphere. This is a problem of Latin America and the Caribbean, involving all of Central America and all of the tropical countries in South America as well. And now virtually every country you can see there has reported Zika virus transmission. I will mention that map is available as a link on the ADPH website. It links actually to the CDC page where that map is updated regularly as there are new reports. Now, Zika was first isolated in 1947. Some researchers from the Rockefeller Foundation were studying viruses in apes and monkeys, and they identified this in the Zika forest region of Uganda. The Zika forest is actually the area that gives a name to this virus. Before 2007, there were really only sporadic human cases that had ever been reported. At least 14 cases we know of had been documented, but certainly there were others that probably have occurred and did occur, but simply weren't recognized as Zika or simply weren't reported. Generally speaking, Zika can look like many other types of infections. It has very nonspecific symptoms for the most part, and so that's one reason we may not have really recognized Zika before. Until recently, there was not really thought to be any long-term effects to Zika virus infection as well, so there wasn't a lot of effort in attempting to diagnose and track the number of people who were infected. But about 9 years ago, the first large-scale outbreak was reported outside of Africa, and this was in the South Pacific on Yap Island, which is part of Micronesia. Then about 2 years ago, a very large outbreak occurred in French Polynesia, which includes Tahiti and Maria and some of the other islands there in the South Pacific. Over 28,000 cases confirmed or suspected were reported, and some think the number may be much larger than that. Maybe well over 30,000 cases as well. We know that in 2015, in May, the first locally acquired cases or mosquito-transmitted cases were picked up in Brazil. It's certainly possible that that could have been related to the many people who traveled to Brazil the year before. The World Cup soccer tournament was held in 2014, and there were millions of people from all over the world who visited Brazil. And then the next spring is when we start seeing locally acquired cases of Zika in that country. So currently, the situation is that we have outbreaks occurring in many countries or territories in the Americas here in the Western Hemisphere, not only with travel-associated cases in the lower 48 United States, but also transmission going on in Puerto Rico and in the U.S. Virgin Islands. The mosquitoes, the Aedes mosquitoes that transmit this are found throughout the world. There are certainly people traveling to all parts of the world very frequently, and so it's certainly likely that we're going to see continued spread to other countries as well. The most recent country to have spread was the Cape Verde Islands off the western coast of Africa, and that's been determined to be a Brazilian strain of the virus that has spread to that country as well. All right. We have not seen local transmission or mosquito transmission of Zika virus in the continental United States. There had been some, before this current episode, there had been just a handful of laboratory-confirmed cases in travelers who had returned to the United States after visiting other places with local transmission, but so far no mosquito-based transmission in the continental United States that we know. The number I have here on the slide shows you the most recent numbers from earlier this month. This showed over 500 travel-associated cases reported to the CDC, including 48 in pregnant women, and about 10 cases of sexual transmission as well. The sexual transmission was documented in people who had not traveled but had a sexual partner who did travel, and occurred in areas and times when mosquito transmission was not thought to be possible. So this was presumptively a sexual transmission in those cases. Just since this slide was made this week, new numbers have actually been reported as of yesterday, and now we have reports of about 157 pregnant women in the continental United States who have been infected with Zika virus, and about 122 cases or perhaps more in Puerto Rico. Now, as I mentioned, the cases in the continental United States are over 500 travel-associated cases, but none that have been locally transmitted. In Puerto Rico, however, and other U.S. territories, but predominantly Puerto Rico, we have over 700 cases, as you can see, and virtually all of those have been locally acquired or transmitted by mosquitoes. So with the current outbreaks, we would expect that cases among travelers would certainly continue as the summer months come and people travel to the Caribbean on vacation or on mission trips or other holidays. They're going to be exposed to Zika virus in those places when they're traveling, and we would expect those folks would come back and many times develop symptoms even after they return to Alabama. Because we may have increased numbers of imported cases and because we have the mosquito here in Alabama, it's certainly reasonable to conclude that we might begin to see some local transmission here in our state or certainly in our country. Let's talk a little bit about the incidence and attack rates. The infection rate when a susceptible person is exposed is fairly high. About 73% of people who are exposed do become infected. However, only about 1 in 5 of those folks actually develop symptoms, so only around 18% in this study that came from Yap Island from 2006. So around 80% of people who become infected do not actually realize that they are infected. The virus seems to affect all age groups, although adults are more likely to present for medical care. From the Yap Island study, there were no severe disease, no hospitalizations or death. Most people seemed to resolve the infection within a few days, just spontaneously without specific treatment. And at that time, at least, it was not really recognized that there were any problems from any long-lasting problems from the infection. This gives you an idea of the symptoms that were seen with that Yap Island outbreak. Most people had rash, and certainly 2/3 of people had fever and joint pain. Conjunctivitis was present in about half of patients, but this is actually an interesting symptom to note because this is fairly uncommon in some of the other arboviral infections, as we'll show you later. But myalgia, headache, vomiting, and other symptoms were also reported to varying degrees. And you can see that this is overall a fairly typical for many types of viral infections. There are not many findings here that are all that unique for Zika, but something that can be seen with many other things as well. The clinical illness typically is mild. Symptoms last for a few days or for a week or so. Severe disease requiring hospitalization is not common at all, and as we said, about 80% of people do not even realize they have the disease. Fatalities are rare if they occur much at all. There has been one fatality reported from Puerto Rico in an older gentleman who developed a coagulopathy, but by and large, death is a very unusual complication and just not something you would expect with Zika virus in most cases. Besides the pregnancy-related complications, however, there is one other complication that we want to spend a little time discussing. Guillain-Barré syndrome has been reported in patients after Zika virus. It's been recognized in the current outbreak, and in fact, once this connection was made, people have retrospectively looked at the outbreak in French Polynesia a couple of years ago, and it appears that there was an increased incidence of Guillain-Barré syndrome after that outbreak as well, although it just wasn't recognized at the time. Guillain-Barré was first recognized during this outbreak by the Brazilian Ministry of Health, and so CDC is currently working to try to figure out exactly what the link is. We've had 6 cases so far that we know of in the United States and in the U.S. territories following Zika virus infection. Guillain-Barré is not a particularly common illness, but actually is not a single illness as well. It's actually sort of a group of neuropathic illnesses that are probably autoimmune. There's not probably exactly one kind of Guillain-Barré, but perhaps more than one illness that sort of gets grouped into the same group of illnesses. There are probably different mechanisms of action, probably different causes, but it is something that's certainly not unusual to see after certain types of infections, as we'll see. People typically have weakness that is bilateral, involves arms and legs. It can last for several days to a few weeks, sometimes even months. Most people fully recover without any specific treatment, although some people have some residual paralysis or other neurologic conditions. About 1 out of 20 people who develop Guillain-Barré will die typically from respiratory failure and related respiratory complications. We don't always know what causes Guillain-Barré, but certainly there's been a long-standing association with infection as an autoimmune disease that's a post-infectious sequelae. One of the most famous associations that was first recognized was with the 1976 swine flu immunization. Many people developed Guillain-Barré following the use of that vaccine. The most classic association nowadays is with Campylobacter infection. Guillain-Barré is a pretty well recognized, although not very common, complication of having an infection with Campylobacter. And it's been seen with Epstein-Barr virus and even with HIV, as well as a number of other infectious agents. What we know about Zika virus and what we know about Guillain-Barré is certainly consistent. This is in keeping with what we see with other types of infections. There may not be a particular reason that Zika causes Guillain-Barré, but certainly we know it follows many infections, and Zika would certainly fit with what we know about that. It is important for us to distinguish Zika from dengue and from chikungunya. Now remember, these are all arboviruses that are transmitted in the same parts of the world, transmitted by the same mosquitoes, and they have very similar symptoms. And so clinically distinguishing these is usually not possible. Dengue and chikungunya can even cause co-infection, so people can be infected with more than one, and it becomes very difficult to tell these apart without specific testing. It is actually important to rule out dengue and chikungunya because it gives you a lot of information about how the patient is going to do. We'll discuss a little bit later, but with dengue, for example, there is a hemorrhagic fever form of dengue in which people develop coagulopathy and thrombocytopenia, and that has a lot of implications in how you would treat that patient, for example. And so it is important for us to know which of these viruses a person has when they return from the tropics with these rather nonspecific symptoms. I'll show you this slide to give you an idea of how they compare. You can see that all of these viruses have fever, and they all have rash to varying degrees, arthralgia and myalgia. Conjunctivitis is the one thing that does stand out. You can see on the slide, conjunctivitis is reported in a little over half of cases of Zika virus, but is not really a prominent feature with dengue or chikungunya. That said, I certainly wouldn't rely on that as a way to try to clinically diagnose this illness. It should be followed up with appropriate testing, as we'll discuss. Finally, I'll just say this is an information sheet that ADPH has prepared that you're welcome to take from our website. This is a patient information sheet that you might want to give to a patient if you were evaluating them for Zika and then wanted to proceed with testing. And that's all the information I have at this time. I'm going to turn it back over to Dr. McIntyre.
Thank you, Dr. Harris. At this time, I'm going to actually cover the guidance that we have for specimen collection, including shipping and testing and diagnostic tests that are available. As far as the specific diagnostic test, when we're looking at someone that is acutely ill or viremic, we're specifically focusing on the reverse transcriptase test, and this is a PCR test. You all have actually seen recently that there's information related to not just what we can do as far as at the state lab. We have the ability to do both of these tests in serum and urine, which means that we actually, when providers contact us, we ask that they submit serum and urine specimens. This is for people who are within that first week of symptoms. The urine will take it out a little bit further where we can actually capture results from that the viral particles with the testing results at up to 2 weeks, which has actually extended our ability to be able to do that. This is when we're looking at folks that actually have an exposure history, which means that in an exposure history they've traveled to, they've lived in and actually come to the United States, or potentially there's been exposure history from sexual transmission, which we'll cover in more detail in a few minutes. When we look at what we can do at the state lab, our Bureau of Clinical Laboratories actually has the ability to do the triplex test, which is the RT-PCR. We actually test for Zika, dengue, and chikungunya, and this is in the serum specimen. We can only do testing for Zika within the urine, and that means that if the person is within the first week of symptoms, we do this acute test using the serum. If they are potentially a week or further, up to 14 days, we do the urine as far as testing specifically for Zika. There is a commercial test currently available, and it is the Quest Diagnostics lab test. It is also a RT-PCR test, which means it's looking specific for viremia or virus particles. It's looking for the RNA of that virus, and that means that we're looking at specimens within that first 7 days. Now, the MAC ELISA testing is something that we reflexively do at the state lab, which means that if we have a specimen that falls within the category where it's been submitted and it ends up being negative for the PCR initially done, and let's say it's 4 days or greater, we will go ahead and submit for the IgM testing to be done, which means there's not additional specimens that have to be collected. This is the MAC ELISA test, and it's looking specifically for the antibody response. If you all remember the acute viremia, we've already talked about it being really short-term and lived. There's some information that maybe about a week or around a week that we can expect it to actually be in the blood. We know that it stays longer in the semen, but there's not currently testing available for the semen that we can do. We also perform this MAC ELISA testing in pregnant women between 2 to 12 weeks after return. This is actually in two categories: asymptomatic women that really have the exposure history, which means they've traveled, they've returned to the United States, and what we do is go ahead and tell the provider when they contact us for consultation that yes, this person needs to be tested, submit a serum specimen, but the test that is done is not the PCR test. And the only testing that is available as far as IgM is currently non-commercially available testing. So on any asymptomatic persons or people that are now beyond that 2-week period of acute symptoms, the MAC-ELISA test is the test that's recommended. The plaque reduction neutralization test. Currently, CDC is the only entity with the ability to conduct this test, which means that when we actually have results from that middle test, which is the IgM antibody, when we get results and we say positive, we can't say that the person has Zika necessarily. The next step, which is there's an algorithm that is followed, is to actually do the print testing. What that means is that the specimen is submitted to the CDC for further testing, and the reason for that is because there is some cross-reactivity between these flaviviruses. Therefore, just because there's a positive test does not mean it's necessarily positive per se for Zika alone. When it's submitted with the print testing, they look at actually whether or not there's a fourfold rise. If it's greater than or equal to a fourfold rise, what we're specifically looking at then is from Zika to Dengue versus the Chikungunya, we can actually say it is Zika. What we've seen with some test results is that actually what happens is we get results that will be positive in all categories, and once the print testing is done, it can differentiate for us whether or not it is Zika testing. This in itself is not 100%. There are some specimens and some people we will be unable to actually say whether it's Zika, whether it's Dengue, whether it's Chikungunya. In those particular patients, what we say is they're flavivirus positive, unspecified, which means they have one of them. And right now, what we're doing is making the recommendation that those specimens are submitted and consultations occur through CDC, through ADPH. There are additional things that can be done. This is usually looking at the fixed specimens, and you'll get more information on that later. We did send out a Harlan alert, and that Harlan alert focused on specifically information related to the fact that we know that there's now a commercial test, but we reminded providers that they needed to contact ADPH for consultation. What we're seeing so far in the results with testing that's been submitted that we're receiving results on from the test done with the commercial lab is that the specimens or the people being tested do not meet the CDC recommendations for testing. They have no out-of-the-country travel history and no exposure history, which means that at this point, because there's not local transmission, there really should not be testing being done in that population for Zika. This has already been explained about the cross-reactivity and why we have to do more than the IgM test before we can actually say that somebody is positive or not. This is what also adds to the time frame and the timing in getting results back. It is a test that requires a lot more to be done with the neutralizing antibodies. If we were able to actually say someone was positive or negative after the initial PCR, we could get results to people a whole lot faster as far as back to the providers. The cross-reactivity with other flaviviruses means that we also, with the vaccines, especially for yellow fever, can get some cross-reactivity, and therefore we have to get histories, which is why the consultation is important. We need to know whether or not they had vaccines, or whether or not, when did they travel, when was the onset of symptoms, if they even had symptoms, which is extremely important. So to ensure that the appropriate tests are ordered and the results are interpreted correctly, please give us a call. This explains the actual collection and shipping. It is available on the website. All of this information is going to be available on the web, including the presentation from today that you can actually pull. And this is the guidance in detail. I am not going to go through it since there is a separate handout that provides it, but it's serum. Especially it tells you about a red top and being able to spin it. and we actually need to keep it cool. I'm going specifically to the information about the most common errors that we see, so that we don't have those, so that you understand what's extremely important that we do. So I'm going through this because this information is available. What we're seeing in specimens being submitted to the lab is that most commonly they're received with no ice, which means that they're unsatisfactory. That means we can't test it. It means that the specimen has to be discarded. No labels. This is category B packaging. There are specific requirements listed in that sheet that explains what must be done, or no consultation, which means the lab can't proceed with doing any testing until we have the information on the consultation form. They won't know what kind of testing to even do unless they actually know whether the person had symptoms, did not have symptoms, when did they travel, when did they return to the United States. All of these things are important. So at this time, I'm going to actually turn this over to Scott.
Thank you. I just want to say a few comments about assessment and treatment as well as prevention. There is no specific antiviral therapy available for Zika, which is true for many viruses, or most viruses, in fact. So treatment then is supportive. So rest and fluids when necessary, medicine for pain, medicine for fever. As we mentioned earlier, it is important for us to not forget about the possibility that your patient could have dengue or could have chikungunya instead of Zika, or in addition to Zika. And as Dr. McIntyre pointed out, we do test for those when testing is done to know for sure. And that primarily relates to the risk for coagulopathy that you see with dengue, hemorrhagic fever. Those folks can go on to develop thrombocytopenia and increased bleeding risk, and so certainly you would want to be aware of that before treating them with, for example, aspirin or nonsteroidal drugs. Even with chikungunya, it's probably important to the patient's prognosis to be able to tell them what to expect. The chikungunya patients can sometimes expect weeks or months of pretty intense arthralgia, and so certainly it would be helpful to your patient to be able to make an accurate diagnosis in that setting so that your patient knows just exactly what to expect. In terms of surveillance, there are certain folks that we would like you to consider evaluating and consider testing. If you have a patient that has an appropriate travel history or an appropriate exposure history, then we would be interested in patients who have fever, who have rash, or who have joint pains, or who have conjunctivitis, particularly within about 2 weeks of a potential exposure or 2 weeks of return from travel to a Zika-affected area. It's important to inform and evaluate women who have been to areas with Zika virus while they were pregnant, even if they did not develop symptoms. We certainly would want you to evaluate those folks. We would suggest that you evaluate the fetus or the infant of women who were infected during pregnancy to see whether there is a possible congenital infection of the fetus or of the infant, and you'll hear more about that in just a few minutes. I'm looking for microcephaly, looking for ultrasound evidence of intracranial calcifications, and so on. And just be aware that local transmission is possible in areas where Aedes mosquitoes are active. If you have patients who return with symptoms and they're in an area with Aedes mosquitoes, which is most of Alabama, then certainly local transmission becomes a possibility. This is an arbovirus, and so that makes it a nationally notifiable disease. We certainly would like to know about these people. There's a number on your screen there for our Epidemiology or Infectious Disease and Outbreaks Division, and we would like to be aware of these patients. Timely reporting is real important to us because we like to know if we have infected patients, particularly women who are pregnant or may become pregnant, but also because we would like to know if we have a reservoir of disease within our community or within our state, so that we can reduce the risk of local transmission, or if we have that, we can mitigate further spread of the virus as well. In terms of prevention, the primary prevention measure is reduced mosquito exposure. There's no vaccine, there's no medication to prevent infection. When mosquitoes are around, avoiding mosquito bites is the primary way to do that. There has been a recommendation that pregnant women should postpone travel to parts of the world where there's ongoing Zika transmission at this time, and we certainly want to continue to get that message out. If people have been to an area where Zika is present, then we would ask them to particularly protect themselves from mosquito bites for about three weeks to prevent further transmission in the event that they are infected. And that protects people in your household, protects people in your neighborhood, so that mosquitoes that bite you there won't be able to take it to those people who live close by to you. Okay. At this time, I'm going to pass this over to Dr. Tom Miller, who's going to talk to you about Zika virus and pregnancy.
Thank you, Scott. And on that last slide, when you mentioned that people who have traveled and returned to the States, they're recommended to use protection from mosquitoes for 3 weeks in order to protect those around them. And that's a nice segue into pregnant women, because there certainly can be some pregnant women around such travelers, and they're a key group that we want to protect. In fact, although Gullian-Barré is not insignificant, the association of Zika virus as a causative agent for birth defects in the unborn fetus is one of the major reasons that it has taken such headline status and has called for such aggressive efforts in terms of preparation and other public health sort of approaches to make sure that we mitigate any potential outbreak in the future to the extent possible. It's important to know that pregnant women right now, there's no proof that they have increased susceptibility to Zika virus when compared to the general population. In addition, infection can occur in any trimester, and that occurs as a maternal fetal transmission, and it also can occur at the time of delivery. There's no evidence to suggest that pregnant women have a more serious illness if infected compared to either non-pregnant women or to males. The comments I'm going to make about Zika and pregnancy are in some ways redundant to some of the information you've heard, but we think it's important enough to mention again. And these are some of the basics that are understood about Zika infection at present. In the pregnant woman, illness again has an onset occurring 2 to 12 days after the mosquito bite. Short-lived, usually symptoms last less than 1 week, and infected individuals usually don't require hospitalization or otherwise experience serious morbidity. As mentioned, Zika virus is now known to be causative for adverse pregnancy outcomes, including birth defects and fetal loss. There is a lot of unfolding parts of this story yet to be determined, but at present some of the other adverse pregnancy outcomes associated with Zika infection during pregnancy include miscarriage, stillbirth, poorly developed brain structures, defects of the eye, hearing problems, and impaired growth. When you are talking to a woman of reproductive age or a pregnant woman, reviewing the nature of the outbreak as it's currently present in the South and Central Americas as well as the Pacific Islands and Africa, is important as a framework, but the other part of that story is that we're expecting a spread of the outbreak with increased international travel, especially with onset of warmer weather, and in particular with heightened levels of vigilance along the coast, Alabama and other coastal states. There's no antiviral treatment, no prophylactic medication or vaccination currently available for Zika virus infection, although the CDC and others are working hard from a research standpoint to develop a vaccine. CDC currently recommends that pregnant women in any trimester do not travel to areas where Zika is present. If travel to these areas is inevitable, such as in a family emergency, a death, or something of that nature, then pregnant women should talk to their health care provider and take very rigorous precautions to avoid exposure to mosquito bites and infection. Pregnant women who have a male partner who has traveled to a Zika-affected area should ask their partner to consistently and correctly use condoms or abstain from insertive sexual activity for the duration of the pregnancy. And we think it's important enough to not assume that a woman in a healthcare setting would always, or even a male for that matter, always know how to correctly use a condom, but that would be another part of the educational process that we want to stress healthcare providers become familiar with in order to convey that information to women who would be so affected. Recommendations for evaluating pregnant travelers. First, this starts with the healthcare provider who is seeing these women in his or her practice setting. They should assertively ask if the pregnant woman has any travel history. Don't just depend on the woman to bring that up or to know to bring it up because she's read an article or seen something on the news media. So we ask the healthcare providers consider aggressively sort of surveying their patient population as they come in with that question. If in fact there is a history of travel to an area with ongoing Zika virus transmission, during the pregnancy, it's incumbent upon the provider to evaluate for symptoms and to test for Zika virus infection. And I'm going to talk about that a little bit. Again, some of this is redundant relative to what Dr. McIntyre earlier presented, but the PCR testing is recommended for pregnant women with a clinical illness, and that's defined as one of the following 4 symptoms, presence of one or more, but remember it only takes one: acute onset of fever, maculopapular rash, arthralgia, or the conjunctivitis during or within 2 weeks of travel to a Zika-affected area. And what this means, the during or within 2 weeks, if you have a woman that comes back on a particular day, then basically you're looking back 2 weeks and forward 2 weeks in terms of that window of time that symptoms, if they developed, would warrant testing with the PCR. If the woman had developed symptoms prior to the 2 weeks before the return, then you would shift in that case to the alternate testing with the IgM methodology. For most women who have a history of travel to an affected area and come back, then, and they are asymptomatic, you would look at testing them within 2 to 12 weeks of return, and that again is focusing on the IgM antibody. When you look at how the body responds to the infection and subsequent production of antibody, the framework for which test is appropriate at which point in time based on the clinical picture is relative to the initial viremia, which rapidly clears here around a week or so after the onset of symptoms, and then the sort of initially overlapping production by the body of the antibodies, in particular here, the IgM. So that's sort of the foundation when you talk about which test, which methodology is appropriate at which point in time in terms of the clinical picture. The laboratory evidence of maternal Zika virus infection includes either the Zika virus RNA detected by the PCR or the positive Zika virus IgM with, as discussed before, the confirmatory neutralizing antibody titers that are at the appropriate level, greater than or equal to 4-fold higher than the dengue virus neutralizing antibody titer. The testing would be considered inconclusive if the neutralizing antibody titers are less than or equal to 4-fold higher than the dengue virus neutralizing antibody titers. And again, that confirmatory neutralizing antibody test is done when the IgM is positive, and it is to try to ferret out whether or not there is a cross-reactivity with other flaviviruses present. The interpretation of the antibody testing can be very challenging because of that cross-reactivity. And again, the viremia decreases rapidly over time. So what this means is even though in general we talk about a week of viremia, you can see towards the end of that week's time frame that the level has dropped to a point that the test might be negative. And this is not something that you can take to the bank, so to speak. As such, it doesn't definitively exclude infection. I wanted to point out that testing is not indicated for women who do not have a history of travel to an area where Zika virus infection is endemic and who do not have a history of unprotected sexual contact with someone who has been exposed to the infection. The algorithm that we're showing now is available on the CDC website, and just briefly, if you look from left to right, you can see that for that pregnant woman with possible exposure to Zika, you're going to do the testing as I outlined earlier based on what window of time you're in relative to the symptoms, or if she's asymptomatic. And you see to the left, if the test is positive or inconclusive, then you would proceed to doing fetal ultrasounds, considering serial ultrasounds to monitor the development of the unborn fetus. If, in contrast, the testing is negative for the Zika virus infection, you would look at doing a fetal ultrasound to detect any abnormalities that might be consistent with the Zika virus infection, the Zika virus disease. And relative to the fetal ultrasound, that will either be abnormal or normal. And you can see how that algorithm branches on the left and right-hand sides in terms of what the next steps would be. But ultimately, if fetal abnormalities are not found on the ultrasound, then you can move through routine prenatal care with that woman. I think this is a good opportunity to point out how much has changed over a very short amount of time as CDC and others have learned more information about this relatively fascinating virus. And an example with the algorithm is that earlier CDC actually had a step that included amniocentesis, and that's been removed because the thinking over time came to appreciate that that really needs to be an individualized decision based on a case-by-case basis and other clinical factors, and a decision made between the woman and her health care provider. I would advise that given all the unfolding aspects of Zika, should a woman end up with positive findings on a fetal ultrasound, that management probably should involve a maternal fetal medicine specialist through consultation to ensure that that woman receives the appropriate care and consultation. What I want to shift to next is two very brief cases, and I'm going to ask you what you think should be done in this situation. How would you manage this patient? Pregnant woman comes into your office, 26 weeks gestation. The history has traveled to Colombia for 1 week or so in May, and she states that she developed a rash and a fever on May 16th, and she presents to your office on May 19th. So she's back on May 14th, rash 2 days later, comes into your office on May 19th. Well, she's first on your question. She's got that history of travel. It was to a Zika-affected area. She has symptoms, and they're within 2 weeks of travel return. Who are you going to call? Of course, you're going to call ADPH IDNO at that phone number to make sure that the testing decision is appropriate for the clinical situation. And then you would move forward as advised by the consultant at ADPH to draw the PCR on this patient, because she's in that window of time when she would be felt to have the viremia. Teaching points with her are that she actually had 2 of the 4 symptoms, but remember that you only have to have 1 for it to be something you can check on your checklist. The second case is a pregnant woman presents to your office at 20 weeks. She also has a history of travel, this time to Mexico. for about a week at 16 weeks, and she states that she had mosquito bites but no other complaints. So how would you manage this individual? Well, she's asymptomatic. Mosquito bites don't count. It's one of those 4 symptoms. She does have the history of travel, and it actually has been 3 weeks, so she's going to fall into that IgM category because she's between the 2 and 12 weeks after exposure. If the IgM result is positive, you would follow it with a confirmatory neutralizing antibodies and either confirm positive or it would become inconclusive. And in that case, you would move into the ultrasound to screen for the Zika-associated congenital anomalies. I should point out that for both examples, although one was, I think, 16 weeks and one was 20 weeks, really it could have been any number of weeks because the fact of the important point is that she was pregnant, and that would be at any gestational age. The same management and considerations still apply. For the woman who actually does have Zika clinically, again, treatment is supportive: rest, fluids, analgesics, and antipyretics. Avoid aspirin until dengue virus infection can be ruled out because of the related risk of bleeding with the hemorrhagic fever. And in pregnancy, you can treat her with acetaminophen for the fever. For a different pregnancy-related reason, NSAIDs in general should be avoided in the second half of pregnancy because of their effect on fetal renal blood flow and the ductus arteriosus. It's important for physicians also to know that the fetal ultrasound might not detect microcephaly or the intracranial calcifications until late second trimester or early third trimester. Even if the IgM is negative, a baseline screening ultrasound should be performed. And if the patient is negative for both the serologic testing and the ultrasound findings, as pointed out on the algorithm, the patient can resume routine prenatal care. As a way of review, Zika virus RNA has been detected in blood, amniotic fluid, semen, saliva, cerebrospinal fluid, urine, and breast milk. When you're looking at the postpartum setting for the patient in whom you think there's been maternal fetal infection, there are some opportunities for confirmation on a tissue basis in terms of testing the different tissues. And you see these outlined here. You can do the histopathologic studies of the placenta and umbilical cord. You also can test placental tissue and cord tissue for the Zika virus RNA, and you can test cord blood for Zika and dengue virus IgM and neutralizing antibodies. Although the virus has been shown to be present in breast milk, there's not been any evidence of viral replication in milk or reported transmission in breastfed infants. So we want to really message strongly that breastfeeding is so important in general that even in a patient who has Zika infection, there's no reason not to breastfeed the infant. So trying to protect pregnant women, a lot of the things that you've heard in terms of mosquito bite avoidance, EPA-registered insect repellents should be used, and these are considered safe in pregnant and lactating women if they are EPA-registered and include DEET. They should be applied after sunscreen is applied to get the best results. Folks are getting out and about a lot more as it's spring and moving on into summer, so wearing sunscreen and mosquito repellents at the same time, important to keep that order of application in mind. And the long sleeve shirts, long pants, the treated clothes, screened in air conditioned rooms, and mosquito prevention strategies day and night. These are other aspects of protecting pregnant women from potential mosquito bites that might carry Zika. Women of reproductive age with current or previous laboratory-confirmed Zika virus infection should be counseled that there isn't currently any evidence that prior infection poses a risk of problems in future pregnancies, specifically birth defects. But it's felt like, as with a lot of viruses, that the body develops lifetime immunity. At least that's the current understanding. What I wanted to close with is that the CDC recently launched a Zika pregnancy registry. This is a national registry, voluntary on the part of the states, but it is to learn about the risk of Zika during pregnancy. And in that regard, the intent is to collect clinical information about pregnancy and the infant from birth through the first year of life. This knowledge will assist in responding to the ongoing outbreak of Zika. And the last slide I have for this portion is that the time points for pregnancy for data collection include the initiation into care, and then second and third trimesters, and then delivery. You'll hear more about what data is outlined to be collected in the infant up to a year of age shortly. And now I will pass this back to Dr. McIntyre.
Thank you, Dr. Miller. You've heard a little bit earlier about sexual transmission and the fact that in the U.S. that we believe there are at least 10 cases, there may be more. This is information that initially we understood from the CDC is that it wasn't, the Zika virus wasn't readily sexually transmitted. And as we've learned, like with Ebola, you know, as we get additional information, sometimes we have to change that information. So we do know now that it is sexually transmitted and that the virus can be sexually transmitted by a man to his male or female sex partners. I think the storyline yesterday was about male-to-male transmission, first case documented. Any of you providers out there receiving information from some of the groups like, Medscape and others actually have seen the article about it. As of May 11th, you've already been told that there were 10 cases of sexually transmitted Zika virus that have been reported in the United States. That we know in the known cases of sexual transmission that these men had symptoms. What the CDC has said is that either the symptoms occurred just after or just prior to the actual transmission. So even if they were asymptomatic, the symptoms recurred so shortly within that these are people that became symptomatic. What we don't know is whether or not that males that are asymptomatic, whether they can transmit. So far, there hasn't been any evidence, but it can be spread before, during, or after the symptoms are present. So the virus is present in semen longer than in blood. Currently, the latest information that we have that has been found up to 72 days. These studies are ongoing. The CDC and others working with the CDC and across the world are actually trying to figure out what this actual time frame is. And just as we've received additional information and provided updates to you all based on that, we'll be doing that as the information changes. So how long is the virus present in semen? We don't know. How long can it be spread through sex? We really don't know, although we do have some pretty good information now where we can at least give some time frames to people about when not to have sex for at least certain time frames, and you'll get that information. If infected men who never develop symptoms, which means asymptomatic men, can actually transfer it, we don't know. So what we want to do is provide you with the information as far as what we do know as soon as we have it. And that's what we're trying to do with these webinars. So if infected men who never develop symptoms can transmit it, or if a woman can transmit it. As of today, there hasn't been documentation or evidence that a woman has been able to give the actual Zika infection to her partner. That may change as we learn more, but we're not aware of any as of today. So additional Zika virus and sexual transmission information shows that there's no evidence that women can transmit it right now. The testing of asymptomatic males is not recommended. We receive consultation requests for them. The reality is that within the recommendations for healthcare providers that CDC has released is that asymptomatic males should not be tested because a negative result does not tell us anything. So a lot of infertility specialists are wanting males to be tested. The reality is that even if they get a negative serum test, they're going to still have to use condoms for the recommendation of either at least 8 weeks or 6 months, depending on whether they had symptoms or didn't have symptoms. So that's extremely important. Couples in which a man had confirmed Zika virus infection or clinical illness should wait at least 6 months after the onset of illness before attempting to become pregnant. What that means is that trying to get a test done to determine whether or not it's okay for this couple to conceive is not what the current recommendation is. What the recommendation is that they consistently use birth control, including condoms, or abstain from sex for a full 6 months. And this is for a couple that travel and in which the male became symptomatic. 4 couples in which the man traveled and did not develop symptoms, which means that he has not had any symptoms consistent with the 4 that we talked about. They should wait, that couple, for at least 8 weeks after departing from that area or returning to the United States before attempting to become pregnant. Those are the recommendations. So if the man's partner is pregnant, what is the recommendation? The recommendation is that there should be no insertive sex. You've heard this before. That means no mouth to penis, no vaginal or anal sex for the duration of pregnancy. So getting a test is not going to determine whether or not this person is potentially able to transmit the virus. The recommendation is either no sex or use condoms correctly and consistently every time. So men who live in an area or are traveling in an area with active Zika transmission should be taking preventive steps that have already been discussed. And those preventive steps include, of course, insect repellents, but also other protective measures that you've seen earlier. If a man develops symptoms of Zika at any time during his travel or within 2 weeks of returning, then the healthcare provider should contact us because what we'll do is discuss and look at the things, and that person can be tested because they're now considered to be symptomatic if they fall within those time frames we discussed. So not having sex is the best way to be sure that someone does not get sexually transmitted Zika virus. And it's extremely important for them to take the protective measures that we've already discussed. At this time, Dr. Landers will actually talk about infants and children.
Thank you very much, Dr. McIntyre. And again, in the last few minutes that we have here talking about the Zika virus, I think what we need to focus on is what we would see at the time that the child is born. Obviously, we've laid some groundwork for the pregnant woman or the woman that would be at risk to deliver a child with the potential Zika virus. Well, let's talk about one of the findings that really has been linked to the Zika virus, and that is the finding of microcephaly. Now, what is microcephaly? We're talking about really a small head in a child, and again, the definitions vary depending on what literature you look at, but for the most part, I think we can accept 2 standard deviations below the mean in infants that are of the same sex and gestational age. And it's important that we measure the head circumference correctly. Now, again, a very obvious microcephaly would be there at the time of delivery, again, and extremely obvious, but there might be some, variation, and so it's very important to really consider head circumference being measured about 36 hours or so after delivery, giving time for the molding to somewhat decrease, as well as the potential for a hematoma. And it's very important that we do the head circumference correctly. We want to use the correct measuring tape. Don't use a stretchy tape. Use something that is very, very well recognized. There are several different brands of tapes that are used for head measurement in infants and young children. And again, we want to measure not only with the correct device, but we want to measure correctly. We want to measure midway, basically, between the eyebrows and the hairline. That's where the front of the tape should fit. It should be above the ears and the most prominent part on the occiput. And again, there are many discussions on how to do this correctly, but I can't stress enough that we do this correctly, do this at the correct time, and use the correct instrument. And we know that the head size is a reliable indicator of the intracranial brain volume, and we know that children with microcephaly very, very, very often have cognitive and developmental issues, and certainly we want to try to identify this finding at birth or very shortly after. Well, what causes microcephaly? Well, again, when we're talking about the Zika virus, we're not thinking that this is a primary microcephaly. Obviously, primary microcephaly occurs as a result of various genetic disorders, specifically the trisomies and also Rett syndrome, just to name a couple. This is really a secondary microcephaly, which are very interesting articles that have just come out indicating an arrest of development, if you will, or destruction of tissue that may have started out to develop normally, and then as a result of this infection, there was a damage to that tissue. It did not continue to develop normally. And in fact, what we have seen in a couple of case studies have been children that had, unfortunately, that died and had ventriculomegaly or cerebellar hypoplasia. So again, we know that it significantly affects the brain tissue. And of course, there are other causes of secondary microcephaly, such as vascular disruption or other diseases. Cytomegalovirus can be a cause of microcephaly. So again, just other things that we are aware of. But again, it's a difficult birth defect to monitor because of an inconsistent definition. So we need to try to ensure that we're measuring correctly, that we're reporting correctly, so that we can identify this. And again, obviously, these are some very good pictures. The first picture being of normal head circumference, head volume, and then the third being a very severe microcephaly is actually some of what we have seen in the pictures with the Zika. And one thing that's been interesting that I have read and noticed is that in some of the cases with Zika, these children have actually had kind of a redundant area of skin or redundant skin folds that you don't see in a lot of other situations of microcephaly, but I think that's a very, very compelling finding. Well, what we do know, obviously, as has been pointed out, is there is a causal relationship between Zika and microcephaly. An article just recently in the New England Journal of Medicine. We know that there have been positive tests for Zika in some of these infants, as well as Zika virus recovered from fetal brain tissue. Obviously, as I mentioned earlier, this is a disruption of development. We've talked about some of the studies that have been cited regarding this. Okay, we don't know the full spectrum of the phenotype. Zika we obviously have associated with microcephaly, but there are some articles now that are indicating that there can be other fetal abnormalities. Specifically, I read some information about arthrogryposis being seen in infants and even leading to what's called a congenital Zika syndrome. So I think we're going to get more information on that. We also don't know what happens depending on the timing. In other words, when did this woman get the Zika virus in the timing of her pregnancy? That could certainly give us more information regarding the fetal abnormalities. And again, the severity of the maternal infection. Was the woman mildly ill, or did she have a very severe illness, including extremely high fever, which we know, can lead to some teratogenic effects. So I think there's a lot more to be said about this. And again, the testing Dr. Mack has discussed very eloquently, so I won't go into that further, except to say that testing is recommended in these groups that we're talking about, certainly microcephaly, intracranial calcifications, other abnormalities, infants born to mothers with positive tests. And I think this also points out is very, very, very important if you have an infant that has been potentially identified before the time of delivery or at the time of delivery, that you consult with the Alabama Department of Public Health so that we can assist in ensuring that appropriate testing is being done. Now, obviously, as we mentioned, again, depending on the time that the mother contracted the Zika in pregnancy, we certainly could do a variety of tests, but again, we would like to assist you in knowing which tests need to be ordered. And talking about clinical specimens, obviously it would be ideal to get umbilical cord blood at the time of delivery. If not, the infant has to be stuck, and we all know as pediatricians that's not a fun thing to do. Now, cerebrospinal fluid can be tested, but it has not been recommended, has not been recommended that infants have an LP under these circumstances if we're looking for Zika, unless the LP is being done for some other clinical reason. So again, cerebrospinal fluid can be tested, but we are not recommending an LP in these particular situations unless the clinician determines that there's another reason for doing that. And again, as Dr. Miller mentioned, the histopathologic evaluation can be done. Frozen tissue can be evaluated. And of course, obviously, if the mother has not already been tested, but we have an infant that has signs that we are very concerned about, severe microcephaly, other signs of congenital abnormalities, then we might want to go ahead and do the appropriate Zika virus testing. Again, recommending appropriate testing. Don't just put all your eggs in one basket on a PCR. Also be aware of the timing that this testing needs to be done, as well as other flaviviruses that we've talked about. And again, we have an algorithm here, and I won't go into that in the interest of time, except to say that this algorithm is available, and if you can really go down two different pathways. Do we have the infant that, as a result of ultrasounds, has microcephaly or intracranial calcifications? And if these infants do have this, then obviously we're going to do not only a complete evaluation, but we are going to do the testing for the Zika virus. If the infant is evaluated and has negative testing for Zika, then we have to look for those other agents that might be a cause of the microcephaly. Now, going to the right of our diagram, considering if there's no microcephaly or intracranial calcification, but the mother has a history that was positive in pregnancy with Zika, then obviously we're going to do our complete physical examination. We're also going to do our testing on this infant, and if it's positive, we'll be following up with additional clinical information. If it's negative, then routine care for that infant. And again, what we all would hope for is negative or no Zika virus testing required in the mother and routine care for the infant. Again, this algorithm is fairly straightforward, but I think it's very important for those of us that are pediatricians or family physicians that are caring for children born to mothers with potential exposure to Zika, have this tool readily available that we can look at. Now again, we're talking about evaluation for all infants with possible congenital Zika virus infection. Obviously, as I mentioned earlier, not only thorough physical examination, which we're going to do, but careful head circumference measurement, do that appropriately, and the complete assessment of the infant in terms of other parameters. As well as if the child has not had, if there was not an ultrasound done in the third trimester of pregnancy that was normal, then a cranial ultrasound is indicated. In addition, many of the findings that we can see, again, the neurologic abnormalities, cognitive, developmental, these are all potential concerns that we would have, as well as other abnormalities such as splenomegaly, hepatomegaly, rashes, other skin lesions. And it's very, very, very important. We want to remember that, we certainly screen hearing at the time of birth, and we're very, very happy that we do that. But OAE or ABR screening certainly needs to be done and followed up within the first month after birth. So I think this points out, again, close follow-up, very close follow-up. Ophthalmologic examination, again, depending on the clinical situation, but ophthalmologic examination done by an examiner familiar with working with children and doing pediatric ophthalmologic evaluation. Again, it would be very important if we have a child identified that has microcephaly that we involve other subspecialists outside of primary pediatric care. We would want a geneticist or a dysmorphologist because we could have another etiology going on here, and certainly because of the neurologic concerns, have a neurologist involved. Infectious disease would be an extremely important part of this evaluation because not only, again, are we considering Zika here, but we have to look at other possibilities. And one study that I just happened to read today was concerning a couple of children that were born in Brazil, actually, and these children died shortly after birth, and the evaluation was done. And, of course, this is where the first time they had actually sequenced the genome for Zika and had actually done that in amniotic fluid prior to the time of delivery, but also specifically checked for other congenital infections such as CMV. And I think that's just really important that we continue to look at data and information to ensure that we are getting all of the scientific backing that we need for this, understanding this disease. And obviously other, as we would call as pediatricians, pretty much routine testing on children with these potential features such as CBC platelets, LFTs, again, depending on the situation. And again, if we had a concern that there were a genetic basis for this, we would do that evaluation as well. Now, again, I can't stress enough that all of us want to be partners with you in evaluating infants who could have congenital Zika virus infection. And we would want this information reported to us, and we are available for guidance. My colleagues here and I, as well as our infectious disease and outbreak nurses, are all available for guidance to support in evaluation. And I think the pregnancy registry is one of the most important things that we have at our disposal now to really track and look at the information regarding these patients. Now again, with the pregnancy registry, as Dr. Miller mentioned, there are data points, there are time points for collection, certainly then neonatal assessment, then information at 2 months, 6 months, and 12 months. And the pregnancy registry has a wealth of information regarding the Zika virus, and you'll hear more from that from us in the future. So again, long-term follow-up, we're going to continue our complete physical evaluation. We'll continue to do our hearing screening. We're going to continue to be doing our developmental screening. We're going to continue to follow the head circumference, all the milestones during the first year of life, and we're going to consult pediatric medical specialists as necessary. Because not only are we looking at the fact that this child has microcephaly and it could be related to Zika, but obviously we want to intervene as early as we can with whatever measures to assist that child and that family in adjusting to this situation. Dr. McIntyre?
So in conclusion, we'd like to do a summary. At this time, also I want to remind you that you can submit questions to us so that we can answer those. But what we want you to understand is that the Zika virus continues to circulate and cause locally transmitted disease in the Americas. In Alabama, because of our climate and because of the presence of the Aedes albopictus mosquito, we expect some local transmission. We hope that we can actually keep it under control, which is where all of you come in as far as looking at the information and making sure that we're focusing on prevention. And the most important thing, because the population most at risk, we know are pregnant women, and then of course those infants that we want to make sure that we avoid disease in. So please focus on reminding your patients of how important it is to use insect repellents and to not travel if they're pregnant. A substantial increase in the rates of congenital microcephaly has occurred and been reported in Brazil, but we also have evidence of reports of women who have traveled to these countries and returned to the U.S. of microcephaly, and not just microcephaly, but of increased fetal loss. So it is extremely important that we recognize this. Pregnant women in any trimester should postpone travel. There's nothing so important as to risk those infants. So what we're really recommending is that please try to postpone travel, and also that if it can't be avoided, to take the appropriate precautions. Contact ADPH for Zika testing approval and consultation. We know that there's a commercial test available, but the commercial test does not link you to the IgM that is going to be needed in the majority of those tests that we're actually seeing results on that are negative, which means that we need and have to go the next step. So at this time, are there any questions?
We have a few email questions.
Okay.
Does it matter when in her pregnancy a woman is infected with the Zika virus as to the severity of the complications?
If you want to answer, you don't have to handle this.
I was reaching for the clicker.
Okay.
Certainly that would depend on what point in time she's infected because of the different developmental stages of the fetus. And part of that story continues after delivery. And as Dr. Landers was pointing out, you have those obvious congenital anomalies like microcephaly, but there's some thought that there may be some very subtle subclinical manifestations long term, and that's why the registry is so vitally important, so we can continue to gather that scientific information, if you will, to try to flesh out the complete Zika story. This is, obviously an infectious agent of virus. It's somewhat similar, and then it's totally different from others that we've experienced in the past, be it rubella or more recently Ebola. But we knew a lot about Ebola because Ebola had been around and was a lot better studied and understood. Zika is just sort of come to the forefront almost, just with lightning speed when you look back over the short amount of time that it's been on the front burner. Challenging those countries that are affected, and certainly for the United States, concerns over the travel-associated infections. And what I think, as Dr. McIntyre pointed out, is the relative inevitability of some local transmission, mosquito-borne transmission, although the thinking at present is that it will be much smaller and contained because of a variety of factors. How we live here, we're not as crowded and things of that nature, but it's a fascinating, daunting, challenging public health challenge.
Okay, another email question. You mentioned breastfeeding. Are you aware of any risk of Zika being transmitted through donated blood?
Yes, there's actually a recommendation, and we're working with blood centers. There is actually a specific thing that we're working on dealing with blood safety. It has been specific recommendation made for when you should actually not use blood within an area that is actually being vetted now, so that, and for example, in Puerto Rico, where we do have transmission locally, a lot of it, they actually stopped using blood that was actually obtained locally and actually started bringing blood in because of the risk of transmission via blood. So we understand that it can be transmitted via blood, that is a risk. There are recommendations that have been put in place. The FDA is making sure, along with other entities, that we work with the blood centers to make sure that this is not a potential risk to anyone within the United States.
Another email question. While the process can be lengthy, do you have any information on the development of a Zika vaccine?
We know that there are a number of major research institutions involved currently that are working towards that goal. There's actually more than one. I can't name them off by hand, but we've been involved with some people that the CDC has actually started working with, because they have to have, in order to do research, they have to have access to specimens, which means they have to have the ability to be able to develop the virus. Develop the vaccine, and that means usually having access to blood specimens and other specimens from testing. So it is happening, and it's on fast track. There was some money from the federal level that was actually kind of identified specifically for research efforts. But we all know that there are many viruses that have been out there for a long time where we currently don't have a vaccine available for, like HIV. People have been working for years trying to get a vaccine available. So yes, it's in progress, but we have no idea when there will be anything available that will be that we can use.
Last question. Can you please give a brief review of how today's specific guidance regarding Zika has been updated from the prior recommendations?
Yes. Previously, when we had the webinar, there was really not any information as far as any time frames, as far as recommendations about how long you needed to wait to become pregnant or try to get pregnant. In fact, the recommendation was don't do it, okay? We now have time frames because there's been work that's been done to identify how long it actually stays in the semen. So based on the most current information we have, those recommendations are all new. The sexual transmission information is pretty much all new. It was not available. The information related to what we know now about what happens in infants has had additional information added to it. It's not just microcephaly and intracranial calcifications. We know that there's a whole list now of specific congenital abnormalities that can occur as a result of the Zika virus infection. And that information is actually available where we can actually get a list, and we have that info on the CDC website. So is anything as far as neurological impact, as far as from a congenital standpoint, and they actually talk about spasticity and some other things being evidence of Zika virus infection. The other additional information we have is actually related to the fact that there has been evidence, regardless of the trimester in which the infection occurred, of some impact of the virus. So what we don't know yet is how severe it is and what the percentage of people that actually are infected, especially pregnant women, who that actually could end up with congenital abnormalities. That's still unknown. But we do know that there's a range from as high as, when in one study, is as many of 29%, okay, to as low in another study to less than 10%. So we know that there are risks that exist.
And I think it's important to note on that aspect of it that if you look at women who have documented infection with Zika during pregnancy, and you have two similarly situated women from a clinical standpoint or a laboratory testing standpoint, you know, it's possible one has a baby that's been affected and has some of these birth defects that we're concerned about, whereas the other might deliver a baby that looks perfectly healthy at birth. And so not every woman who gets an infection documented during pregnancy is going to have a baby that gets affected. But again, that is also part of the ongoing study that CDC's launched in terms of the registry to follow even those healthy appearing infants at birth through that first year of life to make sure there aren't some more subtle subclinical sorts of manifestations.
And on Ending, there's contact information up here. The 1-800-338-8347 is the number that we have on the information. It's also posted on our website to contact us for consultations. In addition, we have a whole web page that's mosquito specific with links to Alabama specific information and also CDC information. We want to tell you that we already know there's additional information revisions coming from the CDC when it comes down to case definitions, how we look at lab results. So there will be updates even to the information that we just gave today. So what we're trying to do is to provide you with the latest information when we have it, and we'll continue to do that. We want to thank you for your time in participating in this webinar today.